Hi, welcome back to my channel. We are going to be discussing on protein energy malnutrition. Protein energy malnutrition is said to be a range of pathological condition arising from coincident lack of dietary protein and calorie in varying proportion. We have the types. It could be primary protein energy malnutrition caused by inadequate food intake. It could be secondary protein energy malnutrition result from an underlying disease condition. Then the predisposing factor, we have either the primary or the secondary. The one that predisposes to primary protein energy malnutrition is a socioeconomic factor like poverty, ignorance, famine, maternal deprivation, early ineffective infant weaning, um, harmful cultural food practices, inadequate breastfeeding. Then the secondary protein energy malnutrition, the causes, predisposing factor includes infection like autoimmune deficiency syndrome, AIDS, tuberculosis, TB, and measles. It could also be infestations like heminthiasis. It could be chronic disease like cancer, chronic renal failure, malabsorption syndrome, congenital like congenital heart disease or cystic fibrosis. Then we have some definitions here that says a low weight for height is wasting and usually indicates an acute malnutrition. Low height for age is stunting and usually indicates chronic malnutrition. Severe wasting is defined as weight for height less than 3 standard deviation or mean upper arm circumference less than 11.5 cm. Severe acute malnutrition is presence of severe wasting and or bilateral edema. Classification system. We have the modified Wellcome classification, the old Wellcome classification, the Gomez classification, the WHO classification based on deficit weight for height or height for age. We have the Waterloo classification as for WHO classification. So the Gomez classification is classifies protein and malnutrition based on the deficit in weight for age. And greater than 90% is normal for the nutritional status. A weight for age greater than 90% is normal for the nutritional status in Gomez. 76 to 90 is first degree malnutrition, 60 to 75 is second degree malnutrition, and less than 60% is third degree malnutrition. Modified Wellcome classification classifies children based on the deficits in their weight for age and the presence or absence of edema. A weight for age a weight for age without edema between 80 to 120% is normal. Weight for age between 80 to 120% with edema is kwashiorkor. Weight for age between 60 to 80% without edema is underweight. Weight for age 60 to 80% with edema is underweight kwashiorkor. Weight for age less than 60% without edema is marasmus. Weight for age less than 60% plus edema is marasmic kwashiorkor. The percentage weight deficit is equal to the observed weight times 100 over the expected weight. The observed weight over the expected weight times 100. That's the percentage weight deficit. Kwashiorkor In the Ghanaian language is called sickness of weakening. Sickness of what? Weakening. So, of weaning, which is like when you are weaning off child from food. It results from inadequate protein intake with fair or good calorie intake. Characteristically affect children who are being weaned between the ages of 1 to 3 years. Clinical features of kwashiorkor include the constant one, the common and the occasional clinical features. The constant clinical features are growth failure, muscle wasting, edema, mental changes like apathy or irritability. The common one is the moon face, skin depigmentation or desquamation, brown sparse, easily plugged hair, pallor, hypothermia, diarrhea. Occasional ones are the flaky paint, dermatosis, skin ulceration or fissuring, enlarged fatty liver, micronutrient deficiency or stomatitis. Then we have the cheilosis or glossitis. Marasmus, Greek language, withering or what? Wasting. Marasmus, this results from deficiency in both protein and calorie. However, calorie deficiency dominates, commonly seen in children between the ages of 6 months and 2 years of age. Clinical features is growth failure, muscle wasting, marked loss of subcutaneous fat, child is irritable but alert, the skin is dry and thin, the hair changes minimal, there is a voracious appetite, there is diarrhea, dehydration, and simian monkey fishing. Marasmic kwashiorkor. Affected children exhibit mixed feature of marasmus and kwashiorkor. Features include, it's going to be grouped based on some certain things: the age, face, mental state, edema, muscle wasting, loss of subcutaneous fat, appetite, enlarged fatty liver, hair and skin changes, prognosis. For kwashiorkor, as we said, it occurs between 1 to 3 years, while that of marasmus is between 6 months and 2 years. That's the age at which it happens. The face, how do they look? Kwashiorkor presents with moon face. Marasmus is a wizened old man or a simian monkey fishing. Mental states. The mental state for kwashiorkor, the appetite. There is appetite. There is apathetic and irritable. They are apathetic and irritable, while marasmus, they are alert and irritable. Edema. Edema is present in kwashiorkor but absent in marasmus. Muscle wasting. For kwashiorkor, muscle wasting is mild to moderate, but in marasmus it is severe. Loss of subcutaneous fat is mild in kwashiorkor and severe in marasmus. Appetite is poor in kwashiorkor, but appetite is good in marasmus. Enlarged fatty liver is present in kwashiorkor but absent in marasmus. Hair and skin changes is profound in kwashiorkor but minimal in marasmus. Prognosis is poor in kwashiorkor but better in marasmus. How do we manage these patients? Emergency care. If a child presents with shock, severe anemia and hypoglycemia with corneal ulceration and the rest. What you do is take your history, do your physical examination, make do your investigation and start your treatment. In the history of these patients, the history, you have to collect the symptoms, the presenting symptom. Usually they are presenting with either a poor weight gain, or they are complaining that the child is having weight loss, or child is stooling, which is diarrhea, or the body is swelling, or the skin is changing. And now the associated symptom is poor appetite, fever, hair changes, apathy, inability, irritability. The detailed dietary history is important. So you want to know if the child was exclusively breastfed, if there is a 24-hour dietary recall, if they can recall their 24-hour diet, frequency of the meal, the adequacy, the density, and utilization of the feed, which we call FADU, which is what? FADU, the frequency, the adequacy, the density of the food, and utilization. Also, you want to note the immunization history, detailed immunization history around other predisposing factor as detailed above, and history of complications, symptoms of sepsis, anemia, hypoglycemia, congestive cardiac failure, and the rest. History of the care. Physical examination. You can do a general physical examination to check the appearance of the child, the mental state, the hair, the temperature, pallor, hydration, edema. Then anthropometry. You want to know if the child has gained weight, the height of the child, the body mass index, the mean upper arm circumference, the height, HC and CC, and skin fold thickness. This hand circumference, and this other one will be chest circumference. I can still remember. So the system, you can do a systemic examination for the child. The systemic examination you want to focus on is mental, neurology, respiratory system, cardiovascular system, the abdomen, the musculoskeletal system. Possible findings could be marasmus. Child is emaciated, which has a prominent rib, joint, and facial bone, with hanging skin fold over the buttocks and thigh. Abdomen is scaphoid or flat. Kwashiorkor. The kwashiorkor, child is edematous with swollen abdomen. The hair has an alternating pale and dark bands, which shows a flax sign. Then also atrophied tongue, papillae, cheilosis are also seen. Investigation to be done. Hematological investigation. Okay, just hold on for me. Hematological investigation done here includes your full blood count with urgent PCV, total lymphocyte count, and erythrocyte sedimentation rate. Microbiology investigation is sepsis workup. Like you can do your blood culture, stool culture, urine culture, or urine MCS. Then do malaria parasites, do retroviral status, and your mantle test, because TB is also a causing factor. Mantle test. Then the biochemistry or chemistry investigation is the serum electrolyte, urea, and creatinine. Check especially for calcium, magnesium, and phosphates. Then you can do a random blood glucose. You can do urinalysis, serum albumin, serum albumin and prealbumin, serum transferrin, micronutrient level like your zinc, iron, vitamin D. Imaging that you can do is either a cranial CT or MRI, then X-ray of the chest, hand, and wrist. You can do that. Then treatment. How do you treat these patients? It requires a team approach, which includes your pediatrician, dietitian, and social workers, and the rest. So many more. Treatment is divided into three main phases. We have the stabilization phase, the nutritional rehabilitation, and follow up. Stabilization, day one. In stabilization phase is day 1 to 7, which is in the first week of admission of that patient. What do you do? This addresses the immediate life-threatening complication or in the child. So these include hypoglycemia, hypothermia, dehydration, electrolyte imbalance, anemia, infection. These are the things that you are correcting immediately. Complication and therapeutic directive. For hypoglycemia case, if the patient is conscious, give 50 ml of 10% glucose orally and start feed with formula 75. If the patient is unconscious, however, give 5 ml per kg of sterile 10% glucose IV and filled with F75 every 2 hours on the first day, then every 2 to 3 hours on the other day, which is on the other days. Then keep the baby warm and start broad spectrum antibiotics. If there is hypothermia, which is axillary temperature less than 35 degrees Celsius, or rectal temperature less than 35.5 degrees Celsius, what you do is to start feed. Place on skin to skin contact with carrier or dress with care, or dress in warm clothes. Then you have to cover the head of the child and provide indirect heat via heater, transformer mattress, or incandescent lamp. Then you have to monitor the temperature every hour, hourly monitoring of temperature, or every 30 minutes if using heater. Dehydration. If there is dehydration, you have to give Restomal. Give Restomal 5 ml per kg every 30 minutes for first 2 hours orally or NG tube. Give 5 to 10 ml per kg in alternate hours for the next 4 to 10 hours. Feed is given in the other alternate hours. Reassess hydration status hourly and stop when rehydrated. Then you give your Restomal after each watery stool, which is 5 to 10 ml per kg. Do not give IV fluid unless the child is in shock. Infection. If there is infection, you treat with a broad spectrum antibiotic. If there is no complication, amoxicillin oral 25 mg per kg twice daily for 5 days. If there is complication, then you give gentamicin 7.5 mg per kg IV or IM daily for 7 days. So you can also give ampicillin, which is 50 mg per kg IV or IM 6 hourly for 2 days. Then oral amoxicillin 25 to 40 mg per kg 8 hourly for 5 days. If there's electrolyte imbalance, you have to give extra potassium 3 to 4 millimole per kg per day and magnesium 0.4 to 0.6 millimole per kg per day for at least 2 weeks. Note, potassium and magnesium are already added in F75 and F formula 100. So you have to reduce sodium intake. You also have to reduce sodium intake. Then correct micronutrient deficiency. Vitamins Vitamin A is given on day 1 under 6 months, 50,000 units, 6 to 12 months, 100,000 units, greater than 12 months, 200,000 units, and repeat on days 2 and 14 for child with high signs of vitamin A deficiency or recent measles. Folic acid in brackets 5 milligram on day 1, then 1 milligram daily. Zinc 2 milligram per kg per day. Copper 0.3 milligram per kg per day, and multivitamin syrup. Iron administration is delayed until the nutritional rehabilitation phase. Another thing about this patient is that the fluid given is usually Resomel, which we call rehydration solution for malnutrition. This is a special rehydration solution for severely malnourished children. Compared to the standard WHO ORS, it has less sodium and more potassium recipe for Resomel. Water is 2 liters. WHO ORS is 1 sachet. Sucrose is 50 grams. And electrolyte or mineral solution is 20 ml. The table below compares the solute concentration of Resomel to the WHO ORS. So compare the standard. We've talked about the Resomel. So the solute, the Resomel, and the WHO ORS. Glucose is present, sodium, potassium, chloride, citrate, magnesium, zinc, copper, and osmolality. Now, the glucose in Resomel is 125, while that in WHO ORS is 111. Sodium in Resomel is 45. That in ORS by WHO is 19. So potassium in Resomel is 40. Potassium in ORS by WHO is 20. Chloride in Resomel is 17. Chloride in ORS is 18. Citrate in Resomel is 7. Citrate in ORS is 10. Magnesium in Resomel is 3. There is no magnesium in ORS. Zinc is 0.3. There is no zinc in ORS. Copper is 0.045. There is no copper in ORS. Osmolarity, which is milliosmol per liter, is 290 to 345 in Resomel, but it is 311 in ORS. Now let's go to formula 75 we are starting with. Formula 75 is specifically formulated low lactose milk with 75 kilocal and 0.9 gram protein per 100 ml, to which potassium, magnesium, and micronutrients are added. It is given 8 to 12 times per day during stabilization to provide basic nutritional needs while complications are being addressed. The formula 100 contains 100 kilocal and 2.9 gram protein per 100 ml with more potassium, magnesium, and micronutrients than F75. It is given during nutritional rehabilitation to facilitate rapid weight gain. Nutritional rehabilitation is week 2 to week 6. Evidence of reaching this phase include return of appetite, reduced or minimal edema, and improvement in the mental state. Transition: F100 is given in the first 2 days at equal volume. F75 was given and then increased by 10 ml per feed until some feed remain uneaten, usually at around 200 ml per kg per day. This is to prevent refeeding syndrome. After transition, give 150 to 220 kilocal per kg per day and 4 to 6 gram protein per kg per day using F100 or ready to use therapeutic food, which is your root I don't want to call it Rutherford, but root RUTF, or family food modified to have comparable energy and protein content. Continue to give potassium, magnesium and micronutrients. Commence iron, which is